I'll do that. And then I might start the Facebook Live a little bit earlier because last time I had it. Okay.
All right, thank you.
Good morning. James, Mr. Elliott, is that, there you are.
Morning, Ron. How are you?
Doing well. Are we going to, when we go to executive, is somebody going to send the a link to that separate from this?
Yeah, I'll cover that.
All right, I just want to make sure.
Yeah, Victoria should be sending that, and I'll explain before it gets sent, Commissioner, but that will be one that won't involve you and the other commissioners.
Oh, it won't?
No, because it's related to that lawsuit in which, well, we'll cover
okay.
it.
All
Yeah.
right. All right. So do we just hang on to this site then and
Yeah.
Okay.
So you all, and I'll cover it, but you all three can stay on this meeting and just sort of put yours, and the others will be asked to go to the executive session. Although I don't think Victoria's yet sent out that link. So
okay. All right. Wanted to make sure.
yeah, you don't have to join in on that one. So there you go.
Hey, had one the other day, so I don't need another one.
Yeah, no, I understood.
All righty. Well, good morning, Stephanie. Good morning, Daleen.
Good
Good
morning.
morning. How are you guys?
Good morning.
LaDon, I don't know if you just heard Mr. Elliott, but we, the three commissioners, will not be on the executive session.
Oh, okay. All right.
We can just stay on this site here,
Okay.
and he'll go through that when we get there.
Yeah,
I guess-
I'll cover it before we get there, and I'll need Victoria to send out the links to the people who will be joining that. But I'll cover it after we get the introduction in. I'll go from there.
Yep.
All right. Thank you. And good morning, everyone.
Good morning, Commissioner. Sorry to scare you the other day in person.
Well, it's kind of funny. We're so used to seeing each other versus at Zoom. I hadn't seen you so long in person. It's kind of funny now, but it was nice to see you again in person. Yeah.
Yes, sir.
Yeah. I like that.
James, you did that to me several months ago.
I know. Well, I yeah.
I just came out of the building that the city bought, the old bank. I came out of the building with a couple others there, and James was there, like, for a second was like, who are you?
All right. I like to stay incognito and not have anybody know who I am. It's better that way.
Yep.
That was a nice event for Judge Parthcott.
It was indeed. Gail is a wonderful human being.
Well, we got about a minute left, and then I will get started here. Morning, everyone.
Morning.
looks like we got everybody.
I don't see Patricia Byers or Dr. Cleary yet.
Yeah, right. I was just scanning that. Yeah.
Dr. Clary is connecting right now.
Morning,
Okay,
everyone.
well, it's 8:30. I'm going to call a meeting to order. And if I will, Mr. Ibach, if you will do introductions of guests and staff.
Okay. Commissioner Anderson,
Here.
Commissioner McKinney,
Present.
Commissioner Lindy,
Here, good morning.
Councilmember Byers, Dr. Atterbury,
Here.
Councilmember Duval,
I saw her.
Present.
Dr. Clary,
Here.
Stephanie Algren,
Here.
Daleen Ackerman,
Here.
Jim Curtis. Okay, and the Acton Health District staff, Andre Fresco.
Here, good morning.
All right, myself, Ryan Ibach, Chase Porter,
Here, good morning.
Melissa Sixberry.
Here.
Patricia
Lillian Bravo.
signed on. Excuse me.
Okay. Lillian Bravo,
Here, good morning.
Sean McGee,
Here, good morning.
Nathan Johnson,
Here, good morning.
Dr. Bard. Dr. Bard. Okay. Jocelyn Castillo. Jocelyn, are you there?
Yeah.
Dr. Barb
Alright.
just signed on.
Okay. Victoria Reyes,
Here.
James Elliott.
Morning.
Okay, and we'll go back to Patricia Byers.
Present, thank you.
All right, Jim Curtis, you on? Okay, and then Dr. Bard.
Good morning.
Okay.
All right. Well, thank you much. Do we have any correspondence from anyone? Letters or any comments from the public?
We do not have any submitted written comments.
Okay, thank you. Now we'll move into executive session and Mr. Elliott will explain the overview of that.
Yeah, so we have identified on the agenda discussing lawsuits which have now been combined under one cause number 21-2-768-39. These are two lawsuits from Angie Gerard, Arthur West. Included within those lawsuits is the Board of Health. In compliance with the statute 4230-110 subsection I, the board has the ability to go into executive session to discuss the litigation, ongoing litigation matters. Because the commissioners are made as defendants in this lawsuit, we will handle this executive session the way that we have done it before, which is excluding the 3 county commissioners from this discussion in executive session. The other board members, you should have now received from Victoria a link to executive session. What we'll do is all other board members other than the commissioners, we will leave this meeting. We will go into executive session at the other link that you have been invited to. We have an executive session in there. We've marked it for 15 minutes. I think we should be able to cover everything at that point. If someone can track that in terms of the time frame, and if we go longer or about to go longer than 15 minutes, we will come back in open session and ask for an extension of time. My hope is we can be done in those 15 minutes. So with that in mind, unless there are any questions before we go into this executive session, please check your emails. You should have a link in there from Victoria. She sent it just a couple minutes ago. You should have a link to an executive session. Is there anyone who's going to be invited in the executive session who does not have the link at this point? I'd say let's identify it for Victoria and ask for it. Is there anybody who has not received it? All right, hearing none, what I'd ask is for the 6 board members who will be joining executive session to leave this meeting now, click on the executive session and work through that link.
All right, well, here we are, gang.
See you in 15 minutes, I guess.
Yeah, yep. Smoke them if you got them. Oh, no, I shouldn't say that at the health board meeting, should I?
Question, I hit the link for the health board executive session, but I'm in this meeting. Is this the wrong one?
No, there's only the 6th board, well, yes.
So
Hi,
I
Dr.
guess
Atterbury.
I hit the Zoom link for the one that's.
Yeah, you're on the public one, and it should, go ahead, Victoria.
Dr. Atterbury, I just sent you a link for an executive session if you want to hop in. If you don't have that, I'm happy to resend it to you.
Okay, send it again. I guess I don't have it yet.
Okay, will do. Thank you.
And sign off this one.
Commissioner Anderson? Well, I'm going to state to the remaining
Yes.
members, oh, Commissioner Anderson, good morning. I
Yes.
just wanted to share that the seated members of the board who are in executive session are requesting an additional 15 minutes, so we anticipate resuming at 9:05.
Okay.
Thank you.
All right, thank you.
All right, thanks, Andre.
All right. Looks like you're back.
Yes, Commissioner Anderson, it's official.
Okay. All right. Well, unless there's comment to be made, we will proceed with the agenda. I kind of jumped ahead here a little bit, Ryan. So I think you've already answered the question to number 4.
Yes, that's correct.
All right, well, we'll move on to number 5 then. The motion to approve all of the items listed with an asterisk are considered routine by the health board and will be enacted at one motion. There will be no separate discussion of these items unless a board member requests, in which event the item will be removed from the consent agenda and considered in its normal sequence of the agenda. The 2 items are July 27, 2022 Health District Board of Health minutes, and the payment of accounts payable and payroll issued July 2022 in the amount of $762,971.03. Do I have a motion to approve?
Tricia Byers, I move to approve the consent agenda as presented.
Been moved. Is there a second?
Dr. Cleary, I'll second.
Dr. Cleary seconded. Any discussion? Hearing none. All those in favor?
Aye.
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 Any opposed? Hearing none. Thank you much. We'll move on to item number 6 then, which is the Health District Spotlight Monkeypox Incident Management Team. And Lillian, Melissa, and Nathan.
All of us this morning. Good morning. Let me just let this slide pull up. Okay, so I know Dr. Bart did do a presentation last month on monkeypox, so a lot of this might be some duplicate information, but it's good to just hear it again. It's not something you deal with every day, so just a reminder on some of this stuff. Next slide. In the agenda today, we'll talk about the monkeypox update, our IMT response, which is incident management team, our partnered approach, and how it aligns with our strategic goals.
Okay.
Next slide. Okay. So what is monkeypox? Kind of a refresher. It's a rare disease caused by an infection with the monkeypox virus that's part of the orthopox virus family. It's similar to smallpox, but it's much milder. And it is not related to chickenpox. Spread completely different. The first human recorded case was in 1970, and prior to this current 2022 outbreak, it was reported in Central and Western African countries. So what's unique about that is the other cases that were found worldwide were people that traveled to these areas where it was endemic, and they and that's how they were infected. So they weren't locally acquired, say like in New York or the United States. Next slide. This is just a look at what we're looking at globally now for numbers, almost 49,000 cases. This is as of Monday's data. 99 locations with monkeypox cases, where 92 of those areas had not historically reported monkeypox. So that just shows how this is spreading globally and not just in the Central and Western African areas. And these are all cases that are where people were exposed within these other countries, having no travel. Next slide. This is a look at what we're seeing nationally right now. All states have cases of monkeypox identified. So we're over 18,000 cases as of Monday's data. Just the map kind of shows you where the more hit areas are: Illinois, New York, California, Texas, where they have a larger amount. Washington, you can see, is not far behind. Next slide. And this is a look at what's going on in Washington State. This was as of Monday's data as well. So there's a total of 445 cases in the state of Washington, most of those being in King County. Our last Board of Health meeting, we had our first case reported on July 26th, which was actually the day before our last Board of Health meeting. Since then, we've had 4 additional cases, so we're at a total of 5. And only 14 cases have reported, or 14 counties have reported monkeypox so far in the state of Washington. Of the Yakima County cases, all of them have been men under 30 and who have either traveled to a high incident area such as King County, or they were exposed by a close intimate contact. Next slide. This is just what monkeypox looks like, along with some of the symptoms. The rash will go in different phases. A person is infectious until that rash is completely, the scab has fallen off and the skin is completely healed. They're infectious during all of these stages of the rash. In addition to the rash, they'll have fever, chills, exhaustion, muscle aches, headache, some respiratory symptoms like sore throat, nasal congestion. And we're finding they can have this rash anywhere on the body. What we're finding with this particular outbreak is that much of it is spread through close sexual contact, and so we're seeing a lot of it in the genital areas. Next slide. Just some more information on how it is spread through direct contact with skin or body fluids of an infected person. It can also be spread through close contact with contaminated items such as bedding or clothing. So if you're sharing a bed with somebody, even if you're not having physical contact, you can still get monkeypox if the person is infected and contaminates the bedding. And then respiratory droplets is low risk, but if you have prolonged exposure to somebody face-to-face contact who has lesions in their oral cavity, you can get monkeypox that way as well. I think now we're moving on to Nathan.
Hey, good morning, everybody. So the benefits of response towards monkeypox is we already have a vaccine and antivirals available in the country and throughout the world to combat this disease. With the vaccine, we are currently using the Jynneos vaccine. This has been approved for the smallpox, or it's an approved smallpox vaccine, and it's been FDA approved since 2019. This is different than the ACAM 2000 smallpox vaccine, which many people remember when they were younger. Older people remember when they were younger getting. So it's a little bit different than that. It does have an EUA, or emergency use authorization, to be able to be used for monkeypox. So they're finding it to be very effective at combating monkeypox as well. And it really helps prevent infection of monkeypox to those who are exposed. So there's currently a very limited amount that the United States has. They're breaking it up and giving it to each state, and then each state gets a limited amount and breaks it down even further to each county. So here in Yakima County, we have a pretty limited amount. So at this point, only close contacts who are public health nurses identified through contact tracing is eligible to get the vaccine. We have worked in a very close partnership with Yakima Valley Farm Workers Clinic and Yakima Neighborhood Health Services. So as our nurses identify close contact who is eligible for the vaccine, we're able to refer them over to one of those clinics, whichever is closest to the patient, regardless of that patient being a patient of that organization. So they don't need to be a farm workers patient. They don't need to be a neighborhood health patient. The organization is able to bill insurance and Medicaid, but has agreed if the patient doesn't have insurance that it will still be covered. So we've really worked in very close partnership with those organizations to have that resource available for our community. With antivirals, we are using the Tecovirimat. Apologize if I mispronounced that. Often referred to as TPOXX. It's a little bit easier to come out and roll off the tongue. And again, this is used for treatment of those who are at high risk for severe disease and are positive for monkeypox. This again has been FDA approved. It's an FDA approved treatment for smallpox, and a little bit different than an EUA. They're utilizing a process called the Investigational New Drug, or an EA-IND process. So they're recognizing it's effective against monkeypox. It's not quite to the EUA status. So basically what this means is providers who prescribe this to a patient has to fill out some pretty lengthy documentation and report everything to the CDC and State Department of Health to track things. Really, it's given to control pain. And again, we have very limited amounts here in Yakima County. The two physicians who are eligible or who are able to actually prescribe it and fill out the EA-IND process are the two infectious disease physicians in the county, so Dr. Barg and Dr. Lee. So any patient, regardless of where they've been seen, the provider will reach out to our public health nurse, say, hey, I have a patient who I think is eligible for TPOXX. Our nurse will work with that provider and coordinate with the infectious disease physician and get everything coordinated. And if that patient does in fact meet the criteria, the infectious disease physician will follow the IND process and prescribe TPOXX. Next slide, please. So regarding emergency response, just a little timeline of what has happened really across the world over the last month or so. July 22nd, the State Department of Health activated their incident management team. They're working very closely, specifically with King County, but with also other LHJs who have active cases. July 23rd, the World Health Organization declared monkeypox a public health emergency. And on August 4th, the United States declared monkeypox a public health emergency. When the United States declares anything a public health emergency, it allows them to utilize things like the Strategic National Stockpile, or the SNS. And this is where we're getting a lot of the TPOXX vaccine and antivirals. The federal government has had some available just in this stockpile for emergencies only. And since then, other local health jurisdictions have began activating their own IMTs, or incident management teams, to really respond to their community's needs. Next slide, please. So in terms of what Yakima Health District has been doing, we've really been working on monkeypox since before we got our first case. We were seeing what was going on not only throughout the world, the country, and certainly the state. We knew it was only a matter of time. So we really started beginning with a work group approach, really starting to talk about some basic communication strategies, how we do investigation or case investigations, and what small-scale administration of vaccine and antivirals would look like. Since then, on August 18th, Yakima Health District did activate their incident management team, also known as IMT. It allows us as an organization to follow the incident command system, which provides a more formal and targeted approach towards response efforts. We utilized a few different things before we activated as trigger points. We were looking for local transmission, and increased staff workload, and wanted to ensure that as an organization, we were able to really be responsive to the community's needs. And once we saw all those three trigger points met, that's when we decided to activate our IMT. Moving forward, we're really looking at community-wide communication campaigns, larger scale administration of vaccine and antivirals. As the supply increases, more and more populations will be eligible for the vaccine. And what an increase in case investigation would look like. We only have 5 cases right now, but if we get an influx of cases, we're looking at different ways internally that we can support our public health nurses and ensure that we're able to be really effective and efficient with our case investigations. And just to note that we are still actively activated for COVID response. So we're activated for monkeypox response, COVID response, and we have our daily jobs that our team has been handling. So we got a lot going on here, and our team's been doing extremely well with handling it all. And next slide, and I think I'll be turning it over to Lily.
Yes, thank you, Nathan. So just as a reminder, so with my role within the IMT is the Public Information Officer, or the PIO. And so as a PIO, I have a team of 3 that helps me to work on these different communication efforts. So as Nathan mentioned, we've been activated, even before having activated, we've been working diligently to provide education and resource to the general public. We've developed a website for ease of use, which is yakimahealthdistrict.org/monkeypox. On that site, you can find a link that will take you to the Spanish version of that website. We don't have a vanity URL for the Spanish site quite yet, because CDC is using 2 terms, viruela de simio and viruela del mono. Once we determine when, we'll also have a vanity URL also for ease of access as well, just like we do with the healthdistrict.org/monkeypox. On that website, we have basic frequently asked questions, as well as a general presentation that can be used by any community member that wants to share more information with their team, their staff, or whoever their population that they serve, just on general information about what monkeypox is and how to assess your risk based on different activities. We've also hosted a couple of Facebook Live events, both in English and Spanish, to give the public a chance to interact with Dr. Barg and get their questions answered. And more specifically, with providers, we've also worked again with Dr. Barg, Melissa, and our public health nurses to keep providers up to date, including creating a provider-facing webpage on our provider resources website, which is providers.yakimahealthdistrict.org. And then we've also hosted a webinar for the providers across Yakima County to make sure that they're up to date on the most recent information and can, again, get their questions answered by our team. We're also sending out provider alerts with the most up-to-date information on vaccines and what we're seeing in the community, as well as testing as needed. And then also, after hearing from parents, meeting with schools officials, we developed messaging and resources for families. We were hearing concerns from families as school began, whether monkeypox was potentially similar to COVID in terms of infectiousness. It's not. And so we developed specific resources for family members so that they could feel comfortable with and have the information they needed to be able to feel comfortable sending their children back to school. Essentially, the resources were explaining the key differences between COVID-19 and monkeypox. So that was developed for the schools and has been sent out. And then also we've made a very focused effort on working with community-based organizations that are reaching our high-risk communities, such as those that live in congregate settings, those that serve youth and LGBTQ communities. And with them, we've worked to create communications toolkits, hosted educational webinars, and also presenting to them by their request. And that's what you see here on the slide is just a list of some of the different initiatives that I've talked through. Next slide. So to conclude, as you've heard throughout our update, even as we work in an emergency response setting, we're always keeping our strategic goals in mind. We want to stress that all of our efforts over the last month were expedited, as all the IMT leads are the same that have worked during the IMT response during COVID. So having the infrastructure in place really helped to expedite our work, since we already had our community partners in place, the process in place, the technical expertise in place, and the systems to allow us to quickly activate and mobilize the necessary partners to respond to the needs of the community. The first strategic goal there, deliver mandated services. We, of course, were able to quickly case and contact investigate the cases of monkeypox, as well as already having the expertise to provide isolation and quarantine guidance to the different partners in the community. With the second goal in mind, developing a network of community partners. Of course, as we heard throughout the presentation, allowing partnerships for off-site vaccine administration with our community health centers, partnering with the hospital for the treatment, identifying respite housing, and again, working with our community-based partners to distribute information. And finally, as I alluded to at the beginning, increase the effectiveness and efficiency of district services by, again, having all these systems in place prior and just being able to quickly mobilize in that manner.
Okay.
And that's it.
All right.
Really, and
Thank you all three. Appreciate it. I'm sorry, Mr. Andre, go ahead.
Oh, Commissioner McKinney has her hand
Yes,
raised.
I was just looking at that. Okay. Commissioner?
Yes, first, and I just wanted to note, looks like Councilwoman Byers had put a note in the chat asking that we receive copies of the communications that have gone out. And I just want to make sure that that was seen. My question is, and I've heard, and I'm not surprised that you were creating some communications to families in school, because what I'm questioning is the communication coming from the health district has not been targeted or specific. And so even on the Facebook page, it says, if you are experiencing a new rash, call your provider. And I think the concern is that, wouldn't it make more sense to say, if you are in this high risk category and you are experiencing this rash? Because a lot of parents are really concerned now going back to school, and perhaps we're creating a bit of a hype here about something that really is only known to be in high. I think Dr. Berg in the last meeting said that it was over 90% of cases, and it seems to be that, based off Melissa's update, 100% of the cases in Yakima County have been males who are sexually active under the age of 30 And so I'm just wondering, can we make sure and change the communication on social media so that it actually says right out of the gate, if you are in this targeted area and you're experiencing this, rather than having everyone look at the health district site and think, oh my gosh, because having kids, you know, there's rashes, there's fevers, everyone's going back to school. And it seems to me that we were doing a disservice if we're causing people alarm when there typically should not be. So that's my question.
Thank you.
Yeah, so I'll start if Dr. Parker Mills, if you have anything to add. So one of the things that I know that's been stressed is that we definitely want people to err on the side of testing rather than not testing at this point in time, because even though, yes, we definitely want to target our communications to high risk categories, anyone can, if they were a close contact to someone, may possibly actually get monkeypox in the future. And so, but yes, we're wanting to be very specific to not cause alarm. And actually that's our goal, is to help minimize any potential alarm where it's just not necessary at this point in time. So that was the intent, was to very clearly state that the risk is extremely low in school settings at this point in time. So happy to look those over again and to see if they're being received in a way that we did not intend.
I think then just specifically then the social media posts, I think that's what I was calling attention to. Can we make our social media posts more targeted?
Well, if I may respond, one of our concerns is that this is not actually a sexually transmitted disease. So one of the realities of living in a community where people are spending time together is that it actually is possible to transmit this to others. So the goal in explaining this and communicating how it spreads is that it's actually perhaps a low risk in a school setting, but the reality is if you live in a home with someone who has monkeypox, or you frequent time with them, you have the potential of receiving. So that is where we want to make sure that people are protected and aware and educated on the fact that it is a communicable disease.
All right, thank you. Ms. Duval.
Yeah, so what I understand and what I heard was actually the opposite of what Commissioner McKinney said. I did not hear anyone say that this was a virus that you get because you're sexually active. I believe anyone can get it. I actually was wondering if there was any recommendations or flyers that we can create for parents, because for myself, having small children, I'm having a difficult time explaining to my small children without alarming them or getting them scared and showing pictures of monkeypox, of how to explain to them what monkeypox is and how we can keep them safe. I know that I take my kids to early learning center and I just tell him, just wash your hands. So for me, it's been hard for me to explain it to small children, and I think that other parents might be having that difficulty too. And I know that Lillian did mention that there is a website. Can you please repeat that a little bit slower, because I didn't catch what you said the website was on, where we could get that information.
Yes, I'll put in the chat box as well and send via email, but it's yakimahealthdistrict.org/monkeypox. But I'll make sure to follow up with all the communications that I referenced today.
All right. All right, Daylene.
Yeah, just kind of adding on to what Commissioner McKinney was talking about. I mean, I realize it's not identified as an STD, but they're, you know, just looking at who's predominantly getting it, does just empirically kind of look like there is some factor going on there. So I was just wondering, in our communication, are we emphasizing that and maybe recommending, you know, to refrain from sexual activity for a period of time, and you know, kind of quarantining and being careful in that respect?
Yeah, Lillian, do you mind sharing the specific work that we've done with the the groups that support the LGBTQIA community.
Yes, thank you, Andrew. That's what I was going to get into. So there's really two different strategies that we're working on. One for the general public, because as we know, yes, absolutely, at this point in time, we are seeing cases amongst a very specific group, as Melissa mentioned, those that are men that are under the age of 30 that for the most part have had intimate contact as their exposure. And that's one. So that's one group that we're wanting to work with. And that's where we've been working with our community-based organizations that serve the LGBTQ community, the youth, and then again, other high-risk communities as well. So for them, we are very much providing very targeted messaging around sexual activity, about how to, and some of those recommendations that you just mentioned, Daleen, based on what the CDC is saying. So that's one particular outreach strategy that we're working on to, again, provide that very targeted, very specific information for those that are being impacted the most. But we're also making sure that the general public is aware of what's going on, because there is that risk that over time, if we aren't able to slow the spread, it'll eventually lead up the cases will be seen amongst children, amongst women, amongst other community groups as well. So we don't want to alarm anyone, but that is the fact that if eventually the disease will spread into the rest of the community. So there is essentially two different strategies going on right now for very specific messaging to those that are being impacted right now, but also a general awareness for the rest of the community in preparation for the future.
And as Lillian said, this is something that we know could eventually spread out to the general community. And the strategy initially was to only test people who were high risk, who you suspected had monkeypox, and the State Department of Health is now saying, because we have it in pediatric patients and women in the state of Washington, if you suspect monkeypox, you should test anyone regardless of their high risk factors, because we're already seeing it going into a general community.
Thank you. Commissioner Lindy.
Yes, thank you, Commissioner Anderson. My question is, as we're looking at the potential spread into the future, and I appreciate you explaining the two education approaches, that there is a target as well as a general one. That seems to make sense based on what Dr. Barg explained about the disease and where the high risk is. It was also mentioned in the presentation that this disease has been around since 1970. It's been confined largely to Central Africa. And I'm wondering, do we have any information from that area of the world that talks about patterns of spread as we're trying to figure out patterns of spread here in the United States?
Anyone wish to tackle that?
Well, I would like to defer to Dr. Barg in terms of expertise, in terms of the spread of diseases, but I will share with you that there's two things, Commissioner Lindsay. I want to be very honest, and I said at the beginning of COVID years ago that no one is expert at understanding how these global patterns are going to actually affect different communities, because it's so new. Having said that, I think what we're seeing worldwide, and we're certainly seeing here in not only our state, but in our community, is that there are patterns of increased viral transmission that have been unleashed. And so I think that we will continue to see this type of response in the future. It is interesting, as you say, when we're talking about things that were normally precluded from spreading or contained in certain areas, and now they're spreading globally. I think this is the future. And Dr. Barg, if you have something far more expert to say, I'm happy to hear it, please.
Dr. Barg.
Yeah, so these patterns of spread probably have to do with the perfect storm of having a population that's very mobile and able to go and visit places in Africa and potentially bring it back. And that's pretty much what's happened. The strain that's brought back may be a little bit different from the strain that's been endemic in Africa, but it's not highly contagious like airborne compared to COVID. So the population under 30 is significant because they don't have smallpox vaccine. So you have a susceptible population that's very mobile. And when that population engages in close contact, you have spread. There is, the education efforts are definitely having effect. We'll see in the next, say, month whether spread increases. But if it doesn't, that would suggest the combination of the availability of the vaccine plus the educational efforts will have had an effect. And I'll actually talk a little bit about that in my session or my presentation.
Thank you.
Thank you.
Anyone else? All right. Thank you much. Now we'll move on to Mr. Porter is going to regale us with his report on finances.
Good morning. Good morning, everyone. I got a couple of things to talk about. So I'm going to start off with the financials, but then I have some budget items that needs to be discussed. We're presenting fee items. So I'm going to move along quickly with the financials in the interest of time. If you have any questions, please just go ahead and interrupt me, and I'll answer your questions. So for the month of July, we had a $85,000 gain in excess revenue, and we had an adjustment, a prior period adjustment loss of approximately $29,000, bringing our total excess revenue to $758,000. So our prior period adjustment has to do with some grants that end in June. Those particular grants, the BCHP, our breast cancer health program, billing is open until August 15th. So as you all know, medical billing is always lagging, always in arrears. So we have to keep that open a little bit longer for them. But the loss that you're seeing is not related to the BCHP program. It's actually related to audit costs. We received some audit invoices for the month of June and July that we actually, since the general ledger was open, we backdated those to July. So our allocated budget for the month of July was 12 million, and our actual revenue is coming in close to 7 million. And then for expenditures, our allocated budget through July was 12.2 million, and our actual expenditures are coming in at 6.2 million. Any questions about the summary sheet? Next page, please. Moving into the income statement. Not much to really note here. As you're seeing is what the same trends that we're seeing all year long. Our federal revenue is coming in under budget quite a bit. But as you all remember, we budgeted last year at this time when we budgeted that we would still be in full testing and full vaccination mode, or at least mobile vaccinations as well. And that's scaled down, and that's the reason for these large differences between actual and budget. Next page, please. This is the continuation of the income statement. Again, not a lot to note here. Any questions about the income statement? Moving into the programs. Again, not a lot to note here. You're seeing here all that gray-brown, I guess, 115 through 405 is our FPHS programs, and those are new programs this year. Other than that, you can see we've been diverting quite a bit to STD 332. For the month of August, we will, because right now we're reviewing July, we will have a monkeypox line item since we dropped IMT this month. Next page, please. This is the continuation of our programs. Same trends that we've been experiencing all year long. Any questions? Okay, next page, please. Moving into our COVID income statement. COVID has really dropped off, and as far as our internal operations, we still have continued COVID operations and COVID expenses. However, our attention is diverting more towards other situations, and it's certainly reflecting in our COVID income statement. Any questions about this? Next page, please. And so through the end of July, we had a 9.9 million in total cash and cash equivalents, a slight uptick from June. We get $500,000 every year at the end of July. The way that posts, that's going to post in August. So there's going to be a large uptick in August. The slight uptick you see in July is just us catching up with DOH invoicing. Any questions about the cash flow? All right, thank you. That wraps up the financials.
All right.
I've got a fee schedule, so we are getting into budget season right now. Ryan is going to review our budget, kind of our budget process. But right now I have the fee schedule. And as you can see here, this is our adopted and proposed. So we have really no updates on this. We're not changing any fees except for the septic clearance. We do have one slight change. Will you move to the next page, please?
Okay, pardon me for a second. Commissioner McKinney has a question, please.
Oh,
Oh,
okay.
yeah, sorry, I did not see that.
Well, it's just a general question with regard to the funding for COVID. Is it reimbursable, or so if it's not spent, we're not going to see a shortfall at the end of the year, I guess is what because it's such a huge part of the overall budget. So.
Oh, yeah, no, we have kind of been shifting operations towards monkeypox, which is right now going to be FPHS driven. But as a shortfall, no, we have quite a bit of grants to draw from, and the FPHS funding is certainly helping making up for any shortfalls.
Okay, thank you, Chase.
You're welcome. Next page, I just wanted to point out here, septic review and septic inspection. As you can see, there's a little gap in the 2022 adopted and the 2023 proposed. We are currently working with the public services on implementing some fees there so that they can, streamline, make the efficient more processing for permitting. I'll let Ryan and Sean get into the details on that, but that's the only real change for our proposed fees for 2022 and 2023.
Okay, thank you.
Thank you.
Any further questions? If not, I will entertain a motion to approve.
I do have a question.
Oh, I'm sorry, I missed you.
I'm sorry, I couldn't find the raise hand button quick enough.
Go ahead.
I just want to know, I don't have a copy of that in my packet. I'm wondering if you can forward the fees list to me, please.
Oh, absolutely. The fee schedule was not included in the packet, so that can be sent out. I also would like to point out that the septic review and the septic inspection, if you put them together, they're the same amount as the septic clearance. Those three are kind of we're taking the clearance and we're breaking it out into the two activities that we have. We're reviewing the build aspects or whatever that's called, and then the actual inspection if we're having to go out and inspect the actual at the site.
All right.
Thank you, Chase.
Thank you.
In that case, I will make a motion to approve the financials as presented.
For July 2022.
Yes, for July 2022. Thank you.
All right. Is there a second?
This is Nyla Duval, and I second.
Been moved and seconded. Any further questions or comments? Hearing none. All those in favor?
Aye.
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 Any opposed? Hearing none. Motion passes. Thank you.
Thank you.
All right. We'll move on now to agency reports and Executive Director Andre Fresco.
Thank you, Commissioner Anderson. Good morning to the board and good morning to those who are watching in Yakima County. I want to thank the board first off for their patience through our spotlight. I know that when we have spotlights, there's often many questions, so I want to thank you for waiting until the end to ask them because it is a lot of information and we always want to make sure that we can get through it. So thank you again to the board. And I just want to mention, you will hear more from Ryan and Sean on our fees, but we have not increased fees. We know that many people in Yakima County are having a tough time, and so it wasn't about increasing fees. It was about changing fees to increase partnerships and create more efficiency. So thank you for that. I did want to share a component of the circumstances that we find ourselves in. It's unprecedented to have a worldwide emergency of this caliber with COVID. It's again something I could never have imagined in my career that we would have two worldwide pandemics happening at the same time. I want to share with you that our commitment at the Yakima Health District is to provide the best level of service and communication we can to the community. We recognize, though, that we have three different areas of focus as we're in the industry. We've got COVID, which is not over for us. We certainly have monkeypox, which is, again, another response. So we're managing two emergency responses, and we have our daily work. what we would call our day job. But that is, again, being responsive to the needs of the community, being supportive of our staff, making certain that we as a team support the community, and also make good on our grants and our responsibilities to the state and federal government. So it's a really incredibly busy time. And one of the reasons, as Nathan indicated, that we have the incident command system in place is to ensure that we have the integrity of efficiency and structure and communication. The reason I shared this with you is that we have a small management team. We are considered a medium-sized local health jurisdiction in our state, but we're certainly small when it comes to managing all of these different responses. And that means that the management team and the staff who are on the incident management team are really collectively working on a number of different initiatives. It's different in larger agencies. In larger places like Oakland County or even the Department of Health, you'll have people who are referred to as detailed to an incident management team, and they need maybe on for 4 to 6 weeks. That is not something that we can entertain here because there's simply too much to do, and we're all working in management to support our team. So I share that with you in full disclosure that we've been able to be successful because we're working on successful past history, communication, and certainly the partnerships that we have with other partnering organizations and community organizations around the county. So that's what I wanted to share. The other that you'll hear more about, I believe, when Nathan speaks, is that there are changes coming to both COVID and monkeypox in terms of vaccines, but we don't know enough yet to share that with the board. We anticipate that there will be more vaccines for both monkeypox and COVID, but the process of that from the federal government to the state government to us is as unclear as it is probably to you. So I share that with in all honesty because part of our responsibility here at the health district is to plan 2 weeks out, 6 weeks out, 6 months out for the changes inevitably that we will see. It's very hard to do so if you don't have proper communication from the federal government. So I don't feel that we have as much information as we need going to fall, but we certainly have heard indications that more vaccine will be coming. I would assume in late fall at this time. That's all for me, unless you have questions.
Any questions for Andre? Seeing none, thank you. We'll move on to Dr. Barg.
Morning.
Good morning.
A quick, well, not so quick, but medium quick update on 4 viruses, including polio. But I want to start with the biggest issue, which is still COVID. We're up to 81,090 cases in Yakima County with 826 deaths. And we're still averaging at the state level, I'm up 1,300 new cases a week. In Washington, the totals are 1.8 million with 14,000 deaths since the onset of the outbreak. Vaccine and Paxlovid are in good supply, and the Paxlovid use is going up. And there was just information showing the utility of using it in mild cases that happen to get hospitalized for mild COVID or for incidental stuff. It's working in that hospital setting as well. In the vaccine front, there's a bivalent vaccine that's currently being tested and should be available by late September. So the old strains and the new strains will be included in this bivalent vaccine. And just as an example of how that's needed, there's a new strain emerging, which is a variant of the B4. As in right now, the B4 and B5 are the predominance, but the variant is increasing in numbers. Another thing that's come up in the last few months, there is a bunch of drugs that have been repurposed with the hope that they would interfere with the COVID infection, but they've all been determined not to work at this point, but with big studies. One of those was Prozac, which is an antidepressant. Another one was antiplatelet therapy. And the third one was ivermectin. Big studies, in fact, multiple studies have shown none of those are effective in changing the course of COVID. Another interesting development, it's not new, but it's being emphasized, is ventilation upgrades, especially in the schools. And one of the things I learned from the CDC website, which addresses that issue, are 2 things. First, that indoor air quality, in addition to reducing the spread of viral diseases, also increases health makes thinking better and therefore performance of the students is better. And the great thing is there is federal funding available to help with this. We have a lot of new schools that have been built recently, and we should find out whether their ventilation capacity is up to these standards that would improve things and decrease risks. Next point, we've made it before that the majority of people at this point are either vaccinated or have been infected. So there is protection against the circulating strains, but we don't know whether we'll have future protection from new variants. It's just not predictable. So we have to keep working on vaccines. We have to keep working on ways of interfering with severe disease. And in light of that, there was a very large study published from Singapore showing vaccine effectiveness. They looked at 2.5 million people who are greater than 30 years old and had received the RNA virus, either Moderna or the Pfizer. And it found that 87.4% effectiveness at preventing severe disease. So for at least those available vaccines, that's quite impressive performance. That protection is durable and lasts at least 6 months and possibly longer. One other item we've talked about over the months is long COVID. The estimate is that about 20% of the patients that have COVID will develop symptoms of long COVID. Most of the cases last 3 months or more, sometimes months. And really the way to deal with this is rest and time off from work. The additional stress of going to work when you're feeling bad seems to prolong this. Most of the definitions of long COVID require a positive COVID test, but that's not always positive, even though people had COVID. The COVID test is actually less accurate in women, so more likely false negative would occur, especially early in the onset of the disease. So some cases of long COVID won't easily be attributed to COVID, and then those folks are going to have trouble with time off. Antibody tests, which could provide proof of having COVID, are really not reliable. The antibody levels change greatly over time, and you'd have to be very lucky to hit it at the right point so it's detectable. One of the things that long COVID does is creates a multi-systemic disease. So there's thinking issues, musculoskeletal issues, GI issues. So there's a lot of disruption in life in people who get long COVID. The one good thing is if you've been vaccinated, the risk drops to about 5%. Boosted people and vaccinated people are the best protected. Okay, so any questions about COVID? All right, I'm going to move on. Some people might have heard of fulminant hepatitis in healthy children. The actual virus that causes that is not known, but it looks like most of the data point to a particular strain of adenovirus called adenotype 41. And there's been several studies done in different countries that show higher prevalence of adenovirus by testing versus other countries. In the US, all of the cases reported have been associated with adenovirus. And it's not cause and effect, it's just that adenovirus serologies or adenovirus other ways of detecting adenovirus have been present in those young kids. Usually occurs in children less than 5 years old, and it presents with jaundice, which means their eyes and skin will be yellow, and then proceeds quickly to liver failure. 14 cases of required liver transplant, which is a huge impact on a young kid. One of the things that they test for in all these kids are hepatitis A, B, C, D, and E, which are all the known strains of hepatitis virus that are circulating. So when you look at these cases overall, it very much looks viral, but the only data we have is that a lot of the cases seem to have evidence of adeno. So that's that we had, to my knowledge, we've had no cases of fulminant hepatitis that look like non-hepatitis virus liver damage. Okay, last of that, and now moving on to polio. There haven't been any cases of polio in the US since 1979. mutated live virus, which is the vaccine that's associated with these cases, is not used in the United States. It's used in developing countries. This can infect non-vaccinated persons predominantly. So if somebody's shedding virus because they received the vaccine or exposed to another person who had it, if you're not vaccinated, the risk of getting polio is much higher, and it's almost zero in patients that have been vaccinated. The US uses an inactivated virus that's injectable instead of the oral virus with the attenuated strain that's used elsewhere. And so that's the update on polio. Basically, in the United States, any cases that have emerged have been transmitted from people who have had it to people who have not been vaccinated. All right, lastly, say a little bit about monkeypox. Can't leave the day without monkeypox. The most important thing, and some of the things brought up by other members of the Board of Health, it does not spread like COVID. It is not airborne. It's droplet or close contact, and it's significant close contact. Some of the things that have been looked at are actually good news. There's no transmission at outside events if people are clothed. So don't go to any nudist colonies. If you go to a store and you want to try on some clothes, there's no risk to trying clothes on that are hanging on the rack or trying shoes on when you're shopping. So we can keep the stores going by going shopping and buying stuff we need. There's no risk with plane travel, no risk riding on public transportation. And most importantly, with today going up to 99, there's no risk going swimming. So casual contact is not sufficient. You have to have intimate and close contact. Right now, across the US and in Europe, where it started earlier, the case counts seem to be going down. And that's a combination of what was said earlier, that there's increasing availability of the vaccine and utilization of it for contacts. And there's been excellent information disseminated among high-risk groups and others. So the number of cases we've had stays at 5, and I don't know what the recent test numbers are. Melissa, do you know how many have been tested?
I believe it was 48 total.
All right.
I'm sorry, 55.
Yeah, that's exactly what we want to see. We want to see lots of testing because testing tells us it protects from further infections, which protect downstream even better. So there have been behavioral changes in the high-risk populations. And that's all adds up to perhaps a decrease in the epidemic. Last thing, there's been a death reported in the United States that occurred in Texas, and the patient was very immunocompromised. So it's not clear that monkeypox caused the death, but it definitely was diagnosed in that patient. So the last thing about the vaccine, it does protect if it's used prior to or soon after exposure occurs. The prior to will happen in the future when the vaccine supply frees up a bit, but for now we're just using it for known contacts of patients who have had monkeypox, and it works. And that's my virus review.
Thank you, sir. Any questions for Doctor?
Dr. Barg, what was the cause of death in the case in Texas?
It's probably due to something else in a highly immunocompromised patient, but they were not specific in the reports.
Any other questions?
I think Sean.
I have a question. So Dr. Barg, I remember several cases of the fulminant hepatitis in children a couple of years ago, including fatalities on the West Coast. And then the subsequent identification of adenovirus, but I hadn't heard anything had changed really in incidents or cases of it recently. What prompted you to add that in?
Just a review of virus infections that have happened in the last 2 years, since that seems to be one of the things that we're all facing. And since you brought it up, Sean, it actually speaks to the efforts to survey and make sure new things are coming down the pike that are recognized and measures are implemented to prevent spread, which means we have to have a very robust public health system and be able to get out in front of things. And we haven't been able to do that on monkeypox and COVID. Part of it was because so much was new with COVID. Monkeypox not so new, but without the surveillance and the ability to mobilize really quick, these issues may occur more. There's a fourth virus I didn't speak about, which is called paroechovirus, and that's I was going to drop that because of time, but since you brought up stuff, it's another virus that's causing disease in very young children. And in older children, it's not a problem. All the kids get it. But again, this is a surveillance issue, looking at wastewater and detecting the presence of virus. And all that has to do with the infrastructure available. And since the 80s, the amount of dollars, inflation adjusted, that have gone into public health infrastructure has dropped. So I don't want anybody to be embarrassed if they want to increase the funding for better infrastructure.
Okay, yeah, I appreciate your intent, because actually now that any child that comes in with hepatitis symptoms, that's an immediate consideration now. And the treatment and approach to it is different, because it was highly fatal in the first cases.
Mr. Anderson,
Yes.
I'd like to recognize that Ms. Ackerman has her hand up.
Yes, Daleen.
You're muted, Daleen.
You muted.
Sorry, thought I had unmuted. You'd mentioned going to the store, trying on clothes, that sort of thing would be fine. But yet in the information on the spotlight, it talked about like bedding and materials that you possibly get it from. So what's the difference there?
Well, the clothing in the store probably has been tried on by far few people than you might see in a household where there's been a case. So things are random in a store, and it's unlikely that people who have terrible rashes are going to go to the store. It's not impossible, but when there's a case in a house and touching the clothing that has fluid on it from the vesicles or bedding or towels, that has a real chance of spreading. So the numbers game makes it safe to go to the store. Of course, if you don't like the store, don't worry about
it. Any other questions for Doctor? All right, seeing none, thank you much. Appreciate it.
You're welcome.
We'll move on now to our Chief Operating Officer, Ryan.
Okay, so there's several things that I want to talk about. The first one is that yesterday we held a board orientation for our new board members. So that was attended by Daleen, Stephanie, and the coroner, Jim Curtis. We talked about what public health is, what it looks like in a nation level, state level, and local level. Got a chance to meet all the people on this meeting in the management team and do a little bit of interaction. So appreciate the three of them attending the board orientation. Hopefully it was useful. The next item is just the budget schedule. So the Board of Health will be receiving the fee schedule today. We will advertise for public hearing next week. At our board meeting on September 28th, there will be a public hearing. So the public can submit any comments if they have any concerns about the fees, and then adoption of the fee schedule. So there'll be a vote at the September 28th meeting. Also at that meeting, we will introduce to the board our budget. And so the first week in October, we will advertise for in the newspaper and on our website and our front desk our budget hearing that will happen on the October 26th meeting. So the October 26th meeting, there'll be the discussion on the budget and a vote for the budget to approve the budget. We do that early in October because we don't have a regularly scheduled meeting in November at the last Wednesday of November or the last Wednesday of December due to the holidays. So we combine those 2 months and have the meeting the first Wednesday of December. And so for some reason the budget does not pass October 26th, then we still have one more meeting where we can work out any details and hopefully have a budget approved by the end of the year. Any questions on the budget? Schedule, timeline? Okay. Okay, on August 5th, the State Department of Health put out our updated K-12 school guidance for COVID. And on August 11th, the CDC put out guidance for K-12 school guidance. Some of the updates for the State Department of Health is that they updated exposure notification requirements. So schools now are no longer required to notify parents and families and students every time there's a case in school. But they are required to have some type of notification in place. So it could be just a weekly email, text message, however they communicate to families, that there were exposures and how many there were. We will continue to put on our website cases and staff and students on our website in schools, because the schools are still required to report to the health district on COVID-19. So we'll keep that updated. Also, there's an update on the definition reporting requirements, like I just mentioned, for COVID, and also revised isolation requirements. So after review of both the State Department of Health guidance and the CDC guidance, also review from the staff that deal with these guidance on a daily basis, and also communicating with the state epidemiologist, Dr. Lindquist from the State Department of Health, that the State Department of Health and the CDC guidance align with each other. And then the last item that I have are Board of Health recruitment. So Jocelyn, can you put on the screen? All right, so we have 3 Board of Health members whose terms expire on December 31st, 2022, the end of this year. So the 2 representative positions who are elected officials from the cities and towns in Yakima County, would be Councilmember Duvall and Councilmember Byers. Their terms expire at the end of this year. And citizen position number 1, who represents public health, healthcare, and providers, that's held by Dr. Clary, expires at the end of this year. So that citizen position number 1, this category consists of persons that are practicing or employed in the county who are, and then there's a whole list of who qualifies. So medical ethicists, epidemiologists, experienced people in environmental and public health, such as a registered sanitarian, the community health worker, a holder of master's degrees or higher in public health, employees of a hospital located in the county, or any of the following providers holding an active or retired license in good standing. So a physician or osteopathic physician, advanced registered nurse practitioner, physician assistant or osteopathic physician assistant, a registered nurse, a dentist, a naturopath, or a pharmacist. So these are the people that that can apply for that position number 1. So as far as the timeline goes, on the next page, so we will start advertising the open positions today. On September 25th, the applications and resumes will be due. On September 26th, we will send candidate information to the Board of Health for the citizen member, and we'll send in candidate information to the Board of County Commissioners for the elected officials. At the regularly scheduled board meeting on September 28th, there'll be a vote on which candidates to interview for the citizen representative position and determine a date for the special board meetings to conduct interviews. Last time we, when we just held this process a couple months ago, it was decided that there'd be 6 people that would be interviewed, and so that decision was made in the board meeting, which 6 are going to be interviewed, and then also we set a time, we set dates for those special meetings because we have to interview the candidates in the public meeting. So in the month of October, we will conduct those interviews of the selected candidates, and we'll figure out as we get close to September 28th the availability of the board members. At the October 26th regularly scheduled board meeting, the board will select a candidate and alternate candidate selection to send to the Board of County Commissioners for final approval and appointment. And then hopefully the Board of County Commissioners will let us know what their time schedule is. According to House Bill 1152, which we've talked about quite a bit, the Board of Health is responsible for selecting the citizen members, and then the Board of County Commissioners are responsible for, once we send them, the Board of County Commissioners, the elected officials, candidates, as far as holding their own interviews and doing their selection process. So then the 3 candidates that are selected, appointed, and approved, their terms will begin for all 3 positions on January 1st, 2023.
Ryan, would you send this schedule out to everybody, please, this timeline?
Absolutely. Yep, I will do that. So if you know of anyone that qualifies for any of these 3 positions, then the deadline is on September 25th. Any questions?
Any questions for Ryan? Commissioner Lindy.
Yes, thank you. So Ryan, this is, I appreciate the information here, and yeah, if we could get the timeline, that would be helpful to us. But on a side note, we don't yet have a representative, a tribal representative on the health board. And I was speaking recently with the chair of the healthcare committee of the tribal council. And she had informed me, according to her, the American Indian Health, AIHC, who's responsible for making the appointment, had not reached out to the tribe yet. And I'm wondering if somebody could follow up with the AIHC to ensure that that communication happens.
Commissioner Lundy, I can respond to that. Thank you for that information. I had spoken to Vicki Lowe, who is the executive director of the American Indian Health Commission, and I was under the impression that she had reached out to all tribes in the state. So this is news to me, but I'm happy to speak with her about that because that's not what I had been told. I was under the impression that the recommendation had been contacted. So thank you for that information.
Okay. All right. Thanks, Andre.
Thank you. Commissioner.
I just wanted to also thank Ryan, and I just wanted to make sure that when you're sending the timeline, to ask if you would be able to have Mr. Elliott reach out to Mr. Don Anderson, corporate counsel for the commissioners, just to make sure that there's some parity in the process.
Yep, thank you for that input.
Yeah. Oh, Ryan, if you could, would you send out that previous slide of the qualifications?
Yes, yeah, we'll send out both of these.
Okay, thank you. Any further
other
questions? Any further questions for Mr. Ryan? Seeing and hearing none, we'll move on then to our local emergency response coordinator, Mr. Johnson.
Good morning, everybody. So just a quick update, tagging along on what Dr. Barg brought up around the bivalent vaccine that was actually approved this morning by the FDA. So it's still pending CDC approval and endorsement, but we'll expect that within the next day or so. So basically, it's targeted towards, as Dr. Barg said, the latest Omicrons, both the B4 and the B5 variants. Moderna and Pfizer will both have one available. Moderna's will be available for everyone 18 and older, and Pfizer will be available 12 and over. Anyone will be eligible for that booster 2 months after their primary series or after their last booster. So we'll be keeping eyes on what the CDC does, and then also once they give that approval, work on getting it available here locally among the providers in the county. Other than that, I've been very busy with monkeypox response and working with the team on that. I just want to highlight that, as mentioned earlier, at this point, only people who are close contacts and who are identified by our public health nurses are eligible for the vaccine in our county. You may see difference within what's going on in other parts of the state, specifically King County, and also other parts of the country. Places with larger case rates received a lot more vaccine, so they're able to kind of start opening it up a little bit more. So King County has already been having community clinics that are targeted towards high-risk individuals, and we're just not there yet with the vaccine supply that we have, but are looking at different strategies. So I think as we work these next couple months, we'll be lots of eyes on trying to get the bivalent COVID vaccine available to our community, and also work on getting more monkeypox vaccine and getting that out into the community in different creative ways. So other than that, that's my update. Happy to take any questions.
Any questions for Commissioner Lindy? You have your hand up.
Yes, thank you. Nathan, just a quick question about the bivalent vaccines. Is that a full approval that it's moving towards right now, or is it emergency use authorization?
It'll still be included under the emergency use authorization if I read it correctly. It came out like 2 hours before this meeting that FDA approved it, so.
Okay, thank you.
Okay, any other questions? All right, hearing and seeing none, we'll move on to Ms. Sixberry.
Okay, I think we've spoken up on COVID and monkeypox. The only thing I will add is that we did meet with the superintendents and the school nurses in our monthly call to just provide education on updated guidance for COVID as well as monkeypox to answer any of those questions. Today is National Overdose Awareness Day, so the Yakima Health District has always partnered with Triumph Treatment Services. We'll be out along with them. We'll be out at Sarge Hubbard Park today to provide education on overdoses as well as provide Narcan to anyone in the community that wishes to get that today. And then also the only other updates I have is we have a new public health specialist starting tomorrow. Her name is Leslie. She comes from the lab at Memorial. And then also we have a new public health nurse that will be starting on October 3rd. And that's in addition, adding a nurse, so not replacing a nurse, but we'll have 3 public health nurses.
Good. All right.
That's it for me.
Any questions for Melissa? Ms.
Thank you.
Byron?
Yes, thank you. So I had it on my calendar to visit the National Overdose Day event. I'm trying to remember where it's at.
At Sarge Hubbard Park.
Thank you.
At 3:30.
I probably won't be there that early, but I'll be there for some period of time. Thank you.
All right. Any further questions or comments? Seeing and hearing none, we'll move on to environmental health with Mr. McGee.
Good morning, everybody. A couple of things to talk about this morning. One, we have a longstanding employee in environmental health. He's been here over 30 years. Will be retiring at the end of the year. So we have begun the recruitment process to replace his position once he departs the health district and enjoys retirement. The idea is that we will get his eventual replacement on staff and as trained up as possible so that we don't experience a dip in our ability to serve the community. So having a independently working environmental health specialist by the time our other staff member retires is the goal. So we are working on that actively, and we recently conducted interviews. So we'll be moving forward in that process soon. The other thing I wanted to, Commissioner McKinney, do you have a question before I move on?
I was happy to say that you already conducted interviews, which means that there were applicants qualified. So I just wanted to say hooray.
Yeah, yes. We were nervous for a minute, but we got a bunch last minute.
Good. Thank you.
The next thing I want to do is go in a little bit of detail about the new fees on the fee schedule around septic clearance. A lot of you may know our septic clearance fee currently is $149 across the board. The health district conducts reviews of building permit cases when there is a septic system involved. We have to approve or disapprove septic clearances on building permits based on encroachment factors, septic system capacity, those, building new garages or structures, make sure they're not being put on top of drain fields or tanks. So the idea of what we're doing is we're trying to cut out steps in the process that make it a little more streamlined and a little more user-friendly on the customer and the respective agencies of Yakima Health District and Public Services. So we've worked closely with Lisa, Marivelle, and Carmen over at Yakima County Public Services to come up with a smaller fee, the $40 fee, which is our septic review. When there's a building permit where a septic system is involved, Public Services will collect that fee, automatically send that over through our permit management system to the health district, and we will be able to approve or disapprove it immediately instead of doing an initial review, telling the customer where they need a septic clearance, and then they have to come in and apply and pay a fee. So the idea is to collect a smaller fee, conduct that review immediately, and the only time we would charge that $109 additional fee for septic inspection is the rare instance our staff physically have to go on site and conduct an inspection on that property. So in the long run, we're saving community members fees on their building projects. And we're speeding up the process in that we don't have to conduct a review, and before we can approve or disapprove anything, you have to collect that larger fee. So it's eliminating a couple steps in the process. It's saving people money overall. And it's making the process a lot more clear between public services and the health district. So just a little detail into that process. I want to thank those public service staff for working with us closely on this and getting this prepared for this year's fee and budget cycle. So that's really all I have to talk about today. We remain busy through the busy season, but we also remain responsive, and we're staying up to date with the projects and inspections that we need to be on site for to get people their approvals and their permits. So, any questions on any of those things?
Any questions for Mr. McGee? Commissioner Lindy?
Not a question, just a comment. Well done. Always good. You've seen some comments in the chat. Just, you know, if we can have be more user friendly to the people we serve, that's awesome.
Yes.
Great.
I'm glad to see that it's going to speed up the process as well. All right, no further questions for Mr. McGee. We'll move on to Miss Lillian.
Thank you. So I'll just have a quick update on our immunization program. So our immunization program staff facilitated a partnership between the Yakima Neighborhood Health Services and Sunnyside School District to host routine vaccine events on August 10th and August 16th at the Sunnyside School District office. Each event brought an estimated of 30 families to get caught up on their routine vaccines, which was great. Yakima Neighborhood Health Services was very pleased with that turnout given the staff available that particular day. So again, this is developed because just to make sure that the children, as they were returning back to school, were up to date on their routine immunizations specifically. And then going into flu season, as we have done previously, we are working with other school districts across the county to get school-based immunization activities through the rest of the school year. So I'll be happy to provide updates moving forward. We've been very happy to be able to provide these events on site to just make it more accessible for families to get those either routine immunizations or flu immunizations, and as of last year, COVID immunizations as well, in a place that's easy for them. And then just a quick update, the government announced that they will no longer be providing free at-home testing kits as of September 2nd. So we'll be updating our website to remove that as a resource, but the state is providing free at-home testing as of now. And we are still providing some to community-based organizations here in Yakima County. And unless there's any questions, that's it for me.
Any questions for Lillian? Seeing and hearing none, thank you very much. Next, we'll move on to the unfinished business, resolution 2022-01, Mr. Elliott.
Well, hello again, everybody. We wondered if someone can pull up the draft resolution for the Board of Health. I believe everybody received a copy of this prior to our meeting, or at least I hope you did. It was sent out, I believe, to everybody last Wednesday, if I got that right. That was our goal, was to get it out to you last week for your review. The goal in trying to do this today is to walk through this resolution where there are suggested changes, questions, comments, things to work through. We will do it here in this meeting. The idea is to work through it now to make sure people understand questions, comments, concerns, changes are raised here. And then the idea will be at next month's meeting, after we go through this process, that there will be what I'll call a final resolution that will be presented to you in order for you to determine whether to approve, vote on it, approve as is. So the idea today, again, was trying to get you that resolution a week in advance, the opportunity to discuss it today. I will say what I tried to do was marry a couple of different areas of legal identified rules that we have. Starting, as you'll see in this, is effective July 1st, 2022 is the new rules related to what we previously had referred to as House Bill 1152. It was a change in how boards of health are to be run. RCW 70.46.031, which is identified here in the second paragraph, that is a statute that deals with one county health district jurisdictions. So those are the requirements. That's where we start. That's what we need to work with. Second then is the Washington Administrative Code. Those are the rules that the Department of Health had created. I believe they actually came into existence post July 1st, and can't remember exactly how many months after that was, or dates that was, or days that was, but it was after. But nonetheless, 246-90 is the Washington Administrative Code that identifies the process, which is the Department of Health's rules interpreting and guiding as it relates to RCW 70.46.031. In addition to this, the county commissioners passed in May 24th, 2022, what is resolution 03-2022. And that was their changes, county commissioners' changes to the Yakima County Code. That is the section that deals with membership of the Board of Health. The Yakima County Code Chapter 6.04.010 covers that section. The county commissioners had made some changes to that. I had a chance to review those, to go through them, and then try and marry it all together in this document that is here before you. The Board of Health now should adopt a resolution, and that's why we're looking at it now. Again, next month, hopefully we'll have it in final form to adopt, that adopts this resolution that covers these areas dealing, and it's focused really on this membership of the Board of Health. I know there are other areas that we may want to deal with as a Board of Health at a later date. I really just want to try and get us focused in on this section and get this one dealt with and on the books. So that was the reason why. There may be other areas, and if anybody has other areas that you see that we want to try and deal with at a later time, we can work through those as well. So with that in mind, hopefully you've all had a chance to review, and it is open for critique, discussion, questions, etc.
Any questions, comments? James, I do have one. Is it also, I see the A and the B on there. Is there a C that delineates the appointment by the Yakima Nation?
So this is page 1 that identifies, this is the membership. So A is the 3 members, the county commissioners. B is the 2 elected officials from the cities and towns. C is the 4 citizen members. Those are the 2 that we identified. Ryan identified one of them earlier. At the end of this resolution, we had also identified sort of where the positions sit.
Okay.
And then D on here is the 1 tribal representative who is a resident of Yakima County selected by the AIHC.
Okay.
As Commissioner Lindy pointed out earlier, Andre pointed out earlier, and as I put in the end, we still do not have this communication from AIHC as to who they have selected. So they are, that 1 individual would make up the 10th member of this board. As we sit, Commissioner, right now, we're still at 9.
Thank you. Any further comments or questions? Any further comments or questions for Mr. Elliott? All right, well, hearing none, we will move on to item B under unfinished business is the proposed motion to approve the settlement related to cause number 21-2-00768-39.
Commissioner, since this is me again, before I get into that, what I'll ask is that the board, we put on next agenda for the end of next month, a motion to approve the resolution that has been sent out to you all in a draft form. So I would ask that we would add that to the agenda for the end of September for adoption.
Okay, thank you.
Okay, so moving on, B, the unfinished business. I identified it here, and it was identified on the agenda as a proposed motion, so the public and all would understand. In theory, there may be a motion made related to this issue. I want to spend a few minutes walking through this case, sort of where things are, and give an opportunity for board members to discuss this to a certain degree. The cause number that's identified here, 21-2-768-39, is now the consolidated cause number for two actions that were previously filed against the Board of Health, the county commissioners, and to certain degrees, individual county commissioners. The two lawsuits, one by Angie Gerard and the other by Arthur West. The two lawsuits have now been consolidated into one case. There has been a recent motion to amend the complaint, which, as I'm watching my emails this morning, there was supposed to be a hearing on it this Friday, but the parties have agreed to allow an amendment of the complaint related to other causes of action or other facts that are being identified by the plaintiffs. Where we are in terms of the process is the two lawsuits have been consolidated. The defendants that still rest in the case are the Board of Health, the county commissioners, Commissioner McKinney and Commissioner Lindy are still in as individual defendants. Commissioner Anderson, who was a part of one of the lawsuits, has previously settled and is out as an individual related to these causes of action. The reason for having this discussion here this morning was to identify a couple of things for the board. As this case is going to begin going forward, I have been having discussions with the plaintiffs in an effort to try and resolve this case in a settlement to get the Board of Health, which is my client, all of you, to try and get the Board of Health out as a defendant in this suit. After a couple of months of discussions and certain filings that have been done, hearings that have taken place, I have now been offered an opportunity to resolve this case on behalf of the Board of Health, resolving it for any and all causes of action brought by Angie Gerard and separately by Arthur West in an amount of $2,000 for Angie Gerard and $2,000 for Arthur West. I can go into the particulars of sort of this process. If you want me to do that, I'm happy to do that. The gist of it is this offer of settlement has been made, and this Board of Health has an opportunity to approve that settlement. My recommendation is the board would consider doing that in an amount of $2,000 for each individual, equating to a total of $4,000, covering total costs and expenses on a lawsuit that through this process, the causes of action against the Board of Health, in my opinion, legally would be difficult at the time of trial to prove by the plaintiffs. I think there is solid ground to protect the Board of Health. But at the same time, the cost of defending the Board of Health through this process could be considerably greater than $4,000. And it is my recommendation that based on this offer to settle the two individual lawsuits for a total of $4,000, my recommendation to you would be to make a motion to authorize the approval of that settlement. And what it would require going forward, if you do make that motion and that decision is made, is if you approve of the settlement, I would go back to the plaintiffs and I would prepare for them a draft settlement agreement. One has not been prepared at this point. I'm not authorized to do that. But if you all authorize the settlement agreement to be drafted and approve of the settlement in that dollar amount, I would send the settlement agreement to the plaintiffs. We would work through, try and get that in final form to where I could present it to you as a full Board of Health at the end of September. That is the process. That is what the offer is that has been made. To the extent that there is a motion on this, it is my recommendation that the three county commissioners who are to a certain degree separate defendants from this suit would recuse themselves from a vote on that decision to approve settlement. It is an interesting dynamic here. I won't go into all the pieces of it, but to the extent that the commissioners would recuse themselves, it would remove any questions or any concerns essentially from the public that something has been done wrong. So my recommendation, and we can have the discussion now. I'm happy to answer any questions or comments that are out there. But my encouragement for you as a Board of Health would be to consider and make a motion to approve a settlement as identified. I'll open it up to the board for any questions or comments you have.
Any comments or questions? I would first suggest that I will recuse myself, and I would ask that the other two commissioners do so as well.
I would not say that they're need to be out of any of the discussion. They have the opportunity, obviously, to be here, or if they have questions about settlement, et cetera, they can ask those. But in terms of a vote on the motion,
yes,
I think
I'm
that makes
voting.
sense.
That's what I,
Yeah.
that was my thrust of that. So,
Okay,
all right. Any further questions or comments for Mr. Elliott?
Dr. Cleary.
Yes, I just have a comment. You know, all these accusations, or virtually all of them, occurred at a time when there were only 4 members of the Board of Health, and I was one of those 4. And I know without a doubt that the Board of Health was not in violation of the Open Public Meetings Act. What individual members may have done outside of the Board of Health, I feel is yet to be proven, but it had nothing to do with the Board of Health or the staff of the Public Health Department. So I'm very disappointed in the lawyers involved in this suit, that they're pursuing something that they know is frivolous to name the Board of Health as a participant. And I'm curious, James, what the settlement would state. I understand the rationale of perhaps saving funds, taxpayer funds, in order to not fight this in court. But I would hate to think that we are admitting something that did not occur. And so can you elaborate how this settlement would be worded?
Yeah, any settlement agreement on this would be a complete denial of liability. I would have that included as a term, and it's a sort of standard term that goes into settlement agreements in order to resolve this. That would be in there. The idea is essentially, Dr. Cleary, that there would be an amount of money that would be paid that essentially goes towards attorney's fees for the parties in terms of having to bring the action. But there would be no admission of liability. There would be a complete denial in terms of what's written in the settlement agreement. To the extent that there's any discussions outside of it, that would be the perspective as well.
Okay, thank you.
Thank you. Any other comments or questions?
Yes.
Patricia?
Again, I can't find the raise hand button, so I
That's right.
So I agree with Dr. Cleary that it is frivolous and was unnecessary, but people do things. Having said that, I will also say that as a matter of expediency and being cautious of taxpayer dollars spent, I think it's, it's probably the wisest decision. I asked the question earlier, and I know that the $4,000 will be paid to the individuals, and they will pay their own attorney fees out of that. So there's not additional attorney fees coming from the Board of Health for this. It'll be our own in-house attorney fees for the representation so far. So just in terms of, the amount of money that could potentially be involved and just to expedite the process, I think that's the best idea.
Is that a motion?
I can make a motion. If so, I would make a motion to authorize approval of the settlement.
In the amount of?
I'm sorry, in the amount of $4,000 total, $2,000 to each individual.
Is there a second on that motion?
This is Dr. Cleary. I'll second that.
It's been moved and seconded. Any further comments or questions?
I would just make the comment, Ron, that I don't agree with, in general, settling what we are characterizing as frivolous lawsuits. It encourages more frivolous lawsuits. With that said, whether you want to settle for a financial decision that seems economically a better decision is one that this board will need to make. But I mean, I think we have extremely low liability here. And frankly, for that reason, I would encourage the fight and not feeding the beast that is giving lawyers payment for filing frivolous lawsuits.
Thank you. Any further comments or questions?
No, just to say, Dr. Atterbury, I respect that position.
And without getting into a lot of detail, Dr. Atterbury, my settlement was 10 times what this number is. Ryan, would you conduct a poll, please?
Yes, so there was an issue on the recusal. I know Commissioner Anderson would like to recuse himself at this time. The other two commissioners, before we go on to vote.
My understanding is you would do roll call, and at that point, they would choose to
Okay.
recuse or abstain.
Okay, that's correct, James?
Yes.
Yes.
Okay, so if you are in favor of the motion, please state yes. If not, please state no. Commissioner McKinney,
I will recuse and abstain from voting.
Commissioner Lindsey,
I will also recuse myself from the vote.
Councilmember Byers,
Yes.
Dr. Atterbury,
No.
Councilmember Duval,
Yes.
Dr. Cleary,
Yes.
Stephanie Algren,
Yes.
Daleen Ackerman,
No.
and Commissioner Anderson.
I would like to recuse myself from voting.
Okay, the vote is 4 in favor and 2 not in favor.
So I appreciate that. What I will do, board, so you understand, is I will prepare a draft settlement agreement to send to the plaintiffs and work with them on trying to put together that settlement agreement. And I will come back to you at the end of next month with a final settlement agreement for your approval at that time, which will also require a motion and then a signature on that. Thank you all.
Thank you. All right. We'll move on now to new business. A discussion to be continued, presentation of data that shows the case of hospitalizations and disproportionately among unvaccinated 99%. And I think you can read the rest of it. Commissioner McKinney.
Thank you. I will note, Commissioner Anderson, that the last situation report seems to have been updated. So I'll just ask if maybe Melissa can speak to that. Is the data now accurate or implied to be accurate at this point? And if you could just walk us through the process as to, what we're able to determine if we were getting inaccurate data and now it's been deemed accurate.
It was all more incomplete data, not so much inaccurate, but there was a lag within the Washington disease reporting system and the Washington immunization system communicating. So those numbers were aligning, they didn't have complete data. So those have now been updated through the Washington State Department of Health. So the numbers now are reflective of the most current complete data that we have.
Okay. I don't have any further comments or questions now that the data has been updated, and I appreciate your looking into that and updating it.
Thanks for being patient with that. It was, we were waiting on other people and it's difficult.
All right. Well, thank you much. Any further comments on that or questions? If none, we'll move on to item B, discuss the differences in the CDC guidance. Again, Commissioner McKinney.
Thank you, Commissioner Anderson. I know that Mr. Ibach touched on this a bit, and I had supplied to Victoria the specific difference, I think, was in the cohorting. So I wanted to see, Ryan, if you were able, I know Victoria was going to pass that on, the difference in the requirements to cohort, which of course specifically for students who are participating in band or athletics. The CDC does not recommend cohorting, but my understanding is that OSPI is still recommending cohorting when there's positive cases, and then they would be required to be quarantining, and obviously that would mean they wouldn't be able to participate in the sport or activity and school. So were you able to look into that? That's the specific question.
Yeah, so yep, I'm just pulling that up right now.
I don't mind listening to the birds in Dr. Clary's background. It's quite nice. I think we're all jealous of you right now.
We are.
I meant to put that on mute, but I hope you're not
Please
hearing the
don't.
wasps
No,
that get by once
that's
in a
all
while
right.
as well.
That's all right.
Okay, yeah, so the information I have, neither CDC or DOH have K through 12 cohorting requirements. The Department of Health does recommend cohorting teams and performing art groups during outbreaks, which is on page 11 of the document. And it's not a there's not a recommendation for everyday operations. So it's just during an outbreak for these groups.
And so what, maybe this is a Melissa question, if you remind me, then what are we considering an outbreak? For these groups?
At this point, it's 3 or more or 10%. But they really did remove all of the requirements. They just listed this as additional mitigation strategies you can use if you are in an outbreak. It also does state that it's just during warm-ups, traveling, and practice, so it doesn't interfere with any competitive events.
And it is
it's not required.
Thank you. Yeah, recommendation not required.
Okay. All right. Well, I guess we'll just, and so when you were meeting with the school superintendents, is it the stance then that we're going to not be recommending that?
What we have communicated with the schools is that here's what the guidance says. There really are no more requirements. Each school has a right to be more strict if they choose. We'll support the schools in their decisions, but we're not enforcing any of these higher requirements than what's been laid out by the state.
Okay. Thank you. That's all I wanted to clarify. I appreciate it.
Cool. Anything else? Any other comments or questions on these items? Well, hearing none.
Sorry, I had my hand up earlier, but
I'm sorry. Go ahead.
Talking about the situation before, as Commissioner McKinney had pointed out, it looks like it had been updated, but I just wanted a little bit more clarification on that in respect to, I mean, it looked like almost like the numbers were swapped, like they had been in the wrong category, but like if additional information was added, like the unvaccinated numbers, it just didn't make sense to me how some things went the other way than you would expect. Like if you're adding numbers to it, fine, but if you're taking away numbers, that didn't make sense to me. But also I was trying to look on the site for like how the community would access this information. And it looks like the information is there, but maybe a different format. But it didn't look like it had been updated. So is that going to be done?
And are you referencing the website?
Yeah, the county website.
Yes, I can take a look to see where the discrepancies are there. So I'm happy to follow up so we can make sure that that's consistent. Thank you for finding that out.
All right. Any further comments or questions? Going once.
Commissioner Anderson, I see Commissioner Lindy's hand up.
Yes, go ahead.
Yes, thank you. Thank you to Melissa for the explanation. And I think this is a prudent approach, and I appreciate it in the fact that, yes, we want to be careful and keep people healthy and safe, but we also know, there's a balance here, and we had some tremendous negative consequences to students over the year and a half they weren't allowed to go to school. So I think giving districts, and organizations the discretion to make their own judgments on this, it seems like a prudent measure. So I'm glad to see that. Thank you.
Thank you. Any further comments or questions?
I would just add that ultimately, I think it comes down to the parents being able to make decisions that are best for their children.
Yes, I agree. All right. I will entertain a motion to adjourn.
This is Patricia. I move to adjourn to our next scheduled meeting on September 28th, I believe, 2022.
Is there a second to that?
Nyland, I second.
Been moved and seconded. Any discussion? Hearing none. All those in favor?
Aye.
Aye.
All those opposed? Here, the motion passes. We are adjourned. Thank you. Very good meeting.
Thank you, everyone.
Thanks, everyone.
Bye all.
Thank you.
Bye.